Welcome to UMDF's Ask the Mito Doc monthly webcast. Today, in honor of National Genetic Counselor Appreciation Day, we look forward to shining a light on genetic counseling and genetic testing with Erin McGinnis with Lurie Children's Hospital in Chicago, Rebecca McClellan with Kennedy Krieger in Baltimore, Colleen Clark Mariscu from Children's Hospital of Philadelphia, Andy McCarty with Clover Genetics in Pittsburgh, and Liz Mizrek with Baylor and Texas Children's in Houston. Our moderators today will be Dr. Diwakar Mithal with Lurie Children's and our very own Nicole Wilson, UMDF Program Manager. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking UCB. Mark your calendars now for UMDF Mitochondrial Medicine 2026, set to take place in sunny Orlando, Florida, June 17th through the 20th. Planning is underway to bring cutting-edge information, networking opportunities, and much more to the mitochondrial medicine community. We hope you will make plans to join us. We would also like to remind everyone about our patient-populated registry. This is the ideal place to help capture the patient experience and overall journey to help us move toward cures and treatments for mitochondrial disease. Information about the biorepository can also be found at umdf.org/mitoshare-registry. Please check it out today. Please note, the information provided in this webcast is for general information only and should not be relied upon as a substitute for professional consultation with a qualified healthcare provider familiar with your individual medical needs. Please consult your primary physician and/or specialist before changing the course of your care.
Hello, everybody, and welcome to tonight's Ask the Mito Doc webinar. We're so glad you're able to join us this evening. And today is a very special and meaningful occasion. It is National Genetic Counselor Appreciation Day. So we want to take a moment to recognize and celebrate the incredible work that genetic counselors do every day. They are often the bridge between complex science and personal understanding, guiding patients and families through diagnosis, helping interpret results, and providing compassionate support during some of the most challenging moments. So thank you for your dedication, your expertise, and your empathy. You make extraordinary difference in the lives of those affected by mitochondrial disease. Tonight's Ask the Mito Doc session is not about interpreting anyone's specific genetic report. Instead, our counselors will show real-world examples to help you better understand how to think about genetic testing results, what questions to ask, and what comes next. This is an open and interactive forum, so please feel free to submit your questions in the Q&A box at any time. And now I'd like to welcome our moderator for this evening, Dr. Mithal.
Hi, everybody. How's it going? I'm Diwakar Mithal. I'm a pediatric neurologist at Lurie Children's Hospital, and I'm affiliated with the UMDF in a variety of ways. I'm really grateful to be here tonight. Thanks, Nicole, for hosting this. Guys, I'm going to jump right into this and introduce you to a number of our genetic counselors who are here tonight, also in celebration of Genetic Counseling Day. We are very lucky most of us to work with genetic counselors who help us understand genetic testing from the clinical side and also our bridge to the patients, if you're patients, to help you understand the results. What we're going to try to do today is walk you through some basic ideas around how we interpret genetic testing results, what to expect when getting genetic testing results, and some of the nuances that come with testing that the counselors are really sort of trained to help you understand. So maybe I can start real quick. We're going to go through a few ideas here from people to get like one really clear takeaway of something that you think a genetic counselor can bring to the table for genetic testing. So I'm going to start with you. Colleen is at CHOP. Go ahead, Colleen. Why don't you tell us one thing you think genetic counselors can really help us understand?
I think, they highlight and I say that we're the bridge. And I think making those family connections, whether it's advocacy or clinical trials, or even just exploring options for testing, when to test, how to test, and who to test, I think is really important, that role that we play with patients.
Andy, I'm going to ask you to unmute and come on screen. Maybe you can tell us maybe something that people can expect or don't realize about genetic testing that you can help them with.
So with genetic testing, one of the things that's challenging is though there are very comprehensive tests and there's very targeted tests. While we like to say, all these tests are very comprehensive, there are portions that are only tested on specific tests, but not other tests. So, this seems like a winding way of saying basically, it's really important to have a team, a genetic counselor, to explain those complex concepts of what is actually being tested on each precise test, so that when you get to the end of that, you ensure that you've actually analyzed what you are looking to analyze. Yeah.
Absolutely. I mean, I just want to highlight one thing you said there, which is that there are a lot of different testing paradigms, a lot of different testing methods, labs where tests are sent, and you, even more than the physician, often know the nuances of those different tests and can help the family navigate what may appear to be conflicting information at times, but just a complex environment that you help them navigate. That's great. My good friend Aaron McGinnis, with whom I was in clinic this morning, maybe you can help us understand a little bit how genetic testing goes a little bit beyond, I mean, genetic counseling goes beyond just ordering tests and interpreting. What else do you bring to the table?
Yeah, so definitely, as you mentioned, we play key roles in the ordering and interpreting process, but we also have a lot of training and expertise in how to actually communicate those results to families. So, translating very technical information to information, hopefully, anyone would be able to digest. We also are able to provide a lot of space for our families to actually start processing these results and kind of think about what they mean for themselves and their family members, identify what supports and resources they might need. We also help families find research opportunities, patient foundations, things like that. So we try to be as comprehensive as possible.
That's great. And in the interest of being comprehensive, Liz, maybe you can tell us a little bit about how, in your relationship with the family, sometimes you can help them understand more beyond the actual patient who's getting tested.
Yeah, I think that's really important, especially with mitochondrial diseases, the family, right? And so being able to start with one person in the family and help everyone else in the family understand, but then also provide testing and education to see, is there anyone else in the family we should screen, and kind of go beyond just the one person we're seeing in the clinic.
That's excellent. Rebecca is going to be our last counselor. That gives us a really concise idea about genetic counseling. What I'd like, Rebecca, for you to do is share anything you didn't hear already, and you get the bonus of telling us why you became a genetic counselor.
Oh, fun. So I think the one thing I didn't hear as clear would be taking that diagnosis and figuring out how it impacts your life as a whole. And many of us, I think, work in rare disease clinics where we have the honor of being able to work with families kind of through not just at time of diagnosis, but ongoing, and get to meet with families kind of through different stages in their life. And I feel like that's a big important role that I can play in helping families sort of navigate sort of where they are in that point in their life and how that diagnosis impacts them. So emotionally, whether it's just coming to terms with what it is and what it means, whether it's coming to terms with they want to start a family and how is that going to look. And so having those kind of life conversations that are not always about the results themselves. It's about the diagnosis and what it means for them. Why I became a genetic counselor, that's fun. Not actually too novel or unique. I mean, I've been in practice for about 24 years now, so I've been bouncing around for a long time. When I started, I went to college, bio pre-med. Very quickly realized how long it would take to be an independent practicing doctor, and kind of made a decision to sort of shift gears and find another way to have a very active role in healthcare. Interesting science, but also always wanted to be patient facing, also always wanted to be supporting patients and families, and kind of found genetic counseling. Very relatively new field 20 some years ago. I mean, they were around, but not like we are now. And it was just a perfect fit. And I love what I do every day, still 20 some years in, which I think says a lot about our field.
It certainly does. And I think you're not alone there. I think you're seeing some head nodding going on. It's a very fulfilling field, clearly. But also there's a self-selection process that goes in, and you guys are all in your hearts really wonderful people who combine scientific brilliance with emotional intelligence and the ability to connect with families in ways that I think doctors are supposed to do, but you guys clearly do it. I've seen it up close in ways that are really remarkable. So I hope all of you that are on the call get to work with genetic counselors one day. We're going to shift a little bit now to move away from the value of genetic counseling and genetic interpretation to some cases to really talk more concretely about genetic testing and its utility for mitochondrial disease. So what we're going to do is have a series of cases. I think you guys know which cases you're presenting. So I'm just going to ask whoever was going with case A, the first case, to unmute and share their slides. And I think there may be one person for whom, Nicole, you're sharing slides. Is that right?
Yeah, if her slides don't work, I'll share them.
Okay, sounds great.
Yeah.
All right, Liz, you take it away. And what I'm going to do very sort of subtly is nudge you to finish within 4 to 5 minutes. Okay.
Perfect. Sounds good. So thank you all for joining. I had the pleasure of talking about a whole family that I got to take care of. So some things I want you to think about as we're going through is the time to diagnosis, our genetic learning curve. So can we learn as quickly as we are seeing families and kind of speed up that gene discovery process? And that symptoms can change over time, and sometimes that can be really helpful. So I'm going to talk about 3 siblings. So I'm going to kind of go through this part a little bit quick, and then I'll get to the meat of it. But our first sibling had growth faltering, which used to be called failure to thrive, infantile spasms, which is just usually arm jerking or leg jerking, developmental delays, and autism. He had a high lactate, and sometimes that can be a strong marker for mitochondrial conditions, and low citrulline and arginine. And those are different amino acids seen in our blood that help us maintain our body and help us grow and develop as we would expect. And so we saw him in 2017, actually a few months right before I started at Texas Children's, and he had negative testing at that time. So we go to sibling 2, and this is a child I got to see in the NICU at Texas Children's. He had hypoglycemia, congenital heart disease, growth faltering, and sideroblastic anemia. So essentially the red blood cells break apart more than they should, so needing transfusions. Also a high lactate and a low citrulline and arginine like his brother. The CMA found a genetic change in a gene that does cause a mitochondrial condition, but you have to have 2 changes in this gene to have the diagnosis. Because his exome sequencing was negative, we sent him to the Undiagnosed Diseases Network to see if, 1, we could find a second change, or 2, was there something else that is his possible diagnosis. So then we go to sibling 3. So I again got to see her in our NICU when she was actually just 1 day old. And I remember getting this consult, and I immediately remembered her last name. And I was like, I know her brother. So that was kind of exciting to get some continuity with this family. And she had very similar symptoms to her younger brother, so heart disease and sideroblastic anemia, as well as a high lactate. And with sibling number 3, we finally have an answer. So she had a genetic change in the ATP5F1A gene, and so it was inherited from her mom. She did also have that small deletion in that NDUFA12 gene. So when we get these results, we want to know what is the genetic conditions associated with this gene, because sometimes there can be multiple conditions associated with the same gene. Does the inheritance pattern make sense for our family? And could this also explain the other siblings' symptoms? So this is a pretty picture of our complex 5. There's 5 different complexes for our mitochondria, and this is the tail end of our complexes. And in this little orange oval, that's where this gene, if it's not working properly, that's where we can see differences. It is autosomal dominant, so unlike the other gene, you just need 1 change in this gene to have the diagnosis. And all of the children typically have an elevated lactate as a child with other symptoms, but those symptoms tend to resolve by around 18 or 8 to 18 months of age. And then they tend to be relatively not asymptomatic after that. And so this is our family. So we thought that this did make sense. We did test brothers, and brothers also had this genetic change. And so it's quite possible that maybe their mom had a high lactate as a baby, but she's now in her late 20s. And I wouldn't remember either as a baby kind of what symptoms I had. And so we do think that this is a likely diagnosis for all four of them. So so I want to tell you kind of where they are now. So our first kiddo is 9 years old. He still has autism, or has autism, but no other symptoms. Sibling number 2 is now 4. He does have some developmental delay and still the anemia, needing transfusions. And then our youngest sibling is 18 months old. She still has that growth faltering and that sideroblastic anemia. And she's starting to get in that period where we would expect the symptoms to resolve. And then we still have a question. So we have a positive diagnosis, but we're also wondering, does this one genetic change in this gene that you typically need 2 changes in, is this causing more symptoms for sibling 2 and 3? And that's to be continued. And so I think the main takeaways is persistence is key. So close follow-up with these families benefits not only families, but also us as well. We can learn from them as much as the families can learn from us. And being able to have that close connection. I think I've talked to this family maybe like 20 different times, and just they, we learn so much from them, more than I think the other way around. And so it's great to be able to work with this family and continue working with them. And also just there can sometimes be rare inheritance patterns in rare conditions as well. So you don't typically see an autosomal dominant condition like this. So this was a great family to work with.
Thanks, Liz. That was fantastic.
Thank you.
I think you bring up a really important point in the persistence of sticking with, relationships. These are not relationships that get forged in one visit. It takes time, it takes a lot of effort and energy on your part and also on the family's part to recognize that this is going to have a long-term value, and that these genetic diagnoses end up changing a lot about your understanding about your child and about your family as a whole. So that's excellent. Okay, we're going to take more questions towards the end. I'm going to try to get through all the cases first. So can I have my next counselor take on their case?
Yes, I believe I am case B.
All right.
So I'm going to highlight a case that kind of goes over the nuances of variants of uncertain significance, which I'm sure all of you potentially have heard of or come across at some point. Let me just share my screen. Okay. Perfect. All right. So as a lot of folks probably know on this call, our entire body is made up of cells. We have hair cells, heart cells, skin cells, and in the center of these cells is where our DNA lives. Some in the majority in the nucleus, but obviously we have some DNA in our mitochondria as well. And our genetic information is essentially like a string of letters that our body reads like an instruction manual to create a protein that then does some sort of job in the body. And for mitochondrial diseases, as you all know, are kind of chronic long-term genetic conditions where a person has a problem with the function of their mitochondria. And when the mitochondria are not functioning the way that they should, the body is not able to get enough energy to do all of the things that it needs to do. So it's either the body's not making enough energy or there's kind of too few mitochondria, but either way, it's an energy problem that affects various parts of the body, especially parts of the body that require lots of energy. And genetic testing, as a lot of you probably know, actually reads through a patient's genetic information letter by letter, kind of looking at differences than what it expected to see from a control sample or a reference. So as you can see here, the reference at this position showed a T. And in our patient, the lab was reading through and saw a C. So that would be a difference. And there are several different types of results you can get from genetic testing, mainly a positive or diagnostic test, meaning the difference, the spelling change identified is thought to be harmful and therefore causes an issue when the body reads and uses that genetic instruction and makes a different or abnormally working protein. You can have a negative result, meaning the kind of lab read through, they did not find any differences. So they found a T as they expected to see. Or you can get what we call a variant of uncertain significance. And that means the lab found a spelling difference, but we just really don't have enough information to say, yes, this is a harmful change. This impacts the gene. This is definitely related to your symptoms, or no, it's not. It's just kind of normal human variation that does not have a negative impact on health and development. And genetic testing can definitely be a gray area. It's not black and white. We do get these variants of uncertain significance a lot on our testing. So one case to highlight this is we saw an 11-year-old with suspected Lee disease based on their clinical presentation. Birth and prenatal history was not overly remarkable. After birth, kind of early on, the patient had an unexplained event, followed by UTI and fever at around 5 months of age, and then was seen at 7 months of age for developmental delays. There were frequent hospitalizations kind of after that in the setting of illness. Where there was lab work that was suggestive of mitochondrial disease, elevated plasma lactate. This patient also had an MRI that showed changes concerning for mitochondrial disorder. And the patient experienced a regression at 17 months without a clear trigger. And so the team was pretty suspicious of a mitochondrial disorder prior to testing. However, both a panel and whole exome sequencing was non-diagnostic, meaning it didn't completely find an answer for this patient's symptoms. It did find one unique variant in a gene called NDUFA10, but it only found kind of one variant and one copy of the gene. The second gene, no variants were found. And this is a autosomal recessive condition where you really need to have two non-working copies of the gene to have that condition. Our patient was thankfully accepted and enrolled in a research study that did a whole genome sequencing, which actually was able to find that second variant that the other tests were not able to find. However, the variant was still classified as uncertain because there was not enough information at that point in time to say both of those variants were indeed disease causing. Here's just a little bit of information about what goes into working up a genetic variant. We look at is it present in the population of people without major medical concerns? Is it present in other patients? And if so, what are their symptoms? We look at the clinical data of our patient and does that match what we expect to see for harmful changes in that gene? We look at research. There's computer programs that help make predictions. Sometimes there's lab studies that looking at the function of that specific variant. And of course, testing of family members and family history. So there's a lot that goes into it. So the next steps for this patient, I kind of just broke down some of the information we did know about the variant. The first variant identified kind of in one copy of the gene had been seen before in a patient. It was present in the general population, but at very, very low frequency. Computer programs and evolutionary tools kind of were unclear. So if you take all of that together, that really is not enough for us to say, yes, this is definitely harmful. The second variant, we also had a bit of information, but still not enough for us to say, yes, definitely harmful. However, we were able to test parents and determine that one variant was inherited from mom, one variant was inherited from dad, and that is what we would expect if we need both copies of the gene to not be working to cause symptoms. So it kind of went in line with the inheritance pattern we expected. And our patients clinical presentation or phenotype was also very typical for what we kind of expected with harmful changes in this gene. So that was kind of enough for our lab to upgrade the classification for likely pathogenic to kind of get us out of that variant of uncertain significance space. However, not every variant of uncertain significance we're going to be able to kind of move one way or another just yet, but here are some kind of questions you can think about asking your provider if you get a variant of uncertain significance on a genetic test. It is kind of a pretty frequent result to get back. And as a reminder, most variants of uncertain significance end up kind of, once we learn enough information about them and we can classify them as something, they end up being likely benign or not harmful. But of course, there are some that we can upgrade, just like the to pathogenic or harmful, like the case I just presented. But you can definitely ask your provider to go through what evidence is available about your variant. You can ask your provider, do your symptoms kind of line up with what's expected with harmful changes in the gene? Ask if testing of other family members might be helpful. Is there other lab work or screening that could be done to further explore this? And always kind of think about reanalyzing the variant over time, because our knowledge and information does change. And always definitely request to see a genetic counselor if you don't feel like you have a detailed enough understanding of the variant. We're in kind of all 50 states and all over the world, and there's a lot of virtual access to genetic counselors as well. So I'm probably over time, so I'm going to stop there so it can go to our next presenter, who I believe is Colleen.
And before you jump in, Colleen, was going to say really quickly that these variants of unknown significance are really challenging, as you can probably tell from Erin's talk. But one thing that I think as a field we're all trying to do is really try to get as far along in our understanding of them as possible. And that does take, again, time and a good relationship with your counselor. I think if you are unable to stay in contact with the people who are trying to do this, then keeping track of this information becomes really hard. So we do want to encourage people to have a good relationship and keep following up on this stuff. Okay, Colleen is going to start. I believe these are her slides. Take it.
Awesome. Yeah. All right, so I'm going to go through a case scenario, which was even in one of the questions about retesting. So going through one of our families, we met a 6-week-old little girl who was transferred from an outside hospital with a pretty early onset Mito condition with lactic acidosis, low blood sugar, and failure to thrive. Normal pregnancy. This was the parent's first child. She did unfortunately lose head control prior to her being admitted to the hospital. And at the time, this was several years ago, now we have some new drugs that can help, but her acidosis was really hard to control. And then unfortunately, she also developed liver dysfunction. And so as things were beginning to progress, the team was even considering worst case scenario of a transplant if that was needed. When we met her, you can see these are growth charts that if anyone thinks of looking at these, this is her weight on this side and her length. And so for her parents, she really should have been in around between the 50th and 75th. So she's much smaller than what we would expect based on her parents. So everything, I always say we're complex humans. So we have to take all the puzzle pieces in together. As well, this is a very complex history. So this is our proband. This is our little girl who we met with the acidosis. These are her parents. And, we had another complicated history over here. Dad actually recently found out that they have a cancer risk related gene. Why that was important, because we did a lot of other testing I'm not going to go into, but when we were talking about transplant, if she was going to need immune suppressants, that was going to need to be known. But then we also, when I mentioned the word mitochondria, the family actually knew what that word meant. And I said, oh, why? How do you know what that word means? And they said, oh, mom said I had a cousin who passed away from mitochondrial disease. So now we have this little one who we met, her mom who's healthy, her mom up here who's healthy, her maternal aunt who's healthy, and she had a male cousin who died at 3 from respiratory failure, had Lee syndrome, complex 4 deficiency, and other related conditions. Our patient at this time, she was only 6 weeks old, did not have Lee syndrome. And so everyone was asking, do they have the same condition, which we will get to. So genetic testing, of course, what could be offered? We did a rapid trio exome at the time. Now this would probably be genome. It was completed in blood, and we also had her mitogenome done as well, both in blood, and it was negative. We didn't find anything. We didn't find any secondary findings. She also thankfully didn't have the cancer risk gene, which was one thing to celebrate, but we still had this really sick little one in our hospital, and we needed to think through this case. So one question was, did we really rule out a maternally inherited mitochondrial DNA disorder? Because, right, we have this other cousin that's making us pause and say, you know, could this be something we're missing? Because we only looked in blood. And so we proceeded forward. She had additional tissue testing. So, you know, when we think about doing other invasive testing, now that genetics is getting so much better, but she was going under sedation already. So she was getting a G tube placed, which really helped her nutrition and growth. We finally were getting her acidosis. But you can see her liver biopsy definitely showed how much her numbers were improving. She didn't need a transplant, but she definitely had a lot of necrosis, fibrosis, which you can see in mitochondrial liver-related diseases. She also had mitochondrial dysfunction seen on activities. Her muscle biopsy, we also got at that time, showed a lot of regate red fibers, so that shows myopathy. Remember, she was little, so she wasn't walking or doing those things yet when she came into the hospital, and also a low complex 4 activity. We did do skin. I use this as a big teaching because she does have a confirmed mito disease eventually, but you can see even in different tissues how different results that can look. And that's really just taking all, as I said, those puzzle pieces together to kind of put things in perspective. So, you know, we managed her like she had mitochondrial disease, her biochemistry, her early history. We did not have a genetic answer. We followed with her, as we were just saying with the other case, keeping up with your team. And so the family was like, mentally, I think we want to have another baby, right? I think we want to do retesting. That's usually when testing or new symptoms come up. And so, you know, she was having some developmental gains, a little bit of expressive speech delay, but she didn't have any other hospitalizations. We kept her out of the hospital during any illness. Parents were really diligent, treating fevers. Everything stayed good. So we, you know, wanted to build their family. We couldn't provide a reoccurrence risk. We actually didn't know what's causing her disease. And until we know, we can't be certain. So we did do an exome reanalysis, and it was positive. She had biallelic variants in a gene known as TRMU. And so one was from the mom, the other one was from dad, you know, and the biggest question, of course, to everyone is, why was this not in her first exome? That's what all parents, that's what we asked the lab. The big thing is, the first thing we say was this condition known. There's new genes, thankfully, being described all the time. We knew about TRMU in 2009, and so we were all frustrated that this was not reported. And so we said, why didn't the lab report this? It's a rare disease, so the variant came from mom, was not known to be associated with disease, so it was not flagged. And the deletion on the previous technology could not have been detected. So they missed it through the pipeline, this variant, the spelling change, and the deletion just wasn't able to be done by that previous method. I'm not going to go in for time's sake for TRMU, but it is a recessive condition. Thankfully, with this, we were able to provide reoccurrence risk counseling. They were unfortunately pregnant, surprisingly. They went to go through IVF, but we were able to test the pregnancy. There's a great paper I shared with Kara. They were able to test the pregnancy, and that other little one has never been in the hospital because we found out the answer. That other cousin, we actually found out, has a different recessive mito disease. So just crazy luck in this family with mito penetrance. And, you know, what we recommend to all families is consider non-genomic testing, right? We need additional data to understand how to best treat, what pathway, are we really on the right path, and other things to consider. And, you know, as we always say, you are the experts of your loved one. Trust your gut and keep up, you know, keep persisting for that diagnosis.
Fantastic. Thank you, Colleen. That is a wonderful case where reanalysis just it can be really baffling to people. You know, why is it, like you said, that we knew about this gene, we looked at the gene, but we didn't catch this? And that is the advances in technology. There have been a couple of questions that have been answered already in the Q&A about how, you know, where to send testing. Does it matter who tests? Is AI going to help us do this? And the answer is yes. All of this is getting better all the time. It is a moving target, but that's the purpose of reanalysis, is that these tools keep getting better. And again, that's something where your counselors are going to be paying attention to that. I get recommendations from my counselors all the time on when to reanalyze and how to sort of think about when the right time to do that is, because there's not a perfect science to it. You know, we say a couple years, but sometimes depending on the test, you might want to do it sooner. Sometimes you might want to wait a little bit longer, depending on what else is out there. So there are a lot of variables to this, but the concept that looking at the genome again, the testing that was already done, looking at it again with new tools can give you an answer is really important to understand. So thank you for that, Colleen.
Thank you. And I'll pass it to Andy, who's next.
Thank you. Let's do it, Andy.
Thanks, Colleen. Bear with me 1 second. I'll share my slides here. Okay. Right. So next I'll review inheritance and how that can impact care and counseling regarding mitochondrial disease. Before going through the specific case, I just want to briefly review some of the inheritance patterns. In short, inheritance patterns are the way traits, like genetic conditions, are passed down from parents to their children. These patterns depend on where the gene is located and how it functions, and it can impact the counseling of family members and risk as well as reproductive decision making. So one of the two more well-known inheritance patterns is autosomal dominant inheritance. This is a mode of genetic inheritance or transmission where a single pathogenic variant is typically sufficient to cause disease, or at least a risk for disease. If one parent carries the changed gene, as you kind of see highlighted here, there is a 50% chance that each child would inherit that change and a 50% chance that they would not, which again, highlighted here. So next we'll go into autosomal recessive. This is a mode of genetic transmission where a genetic change must be inherited from both parents to manifest disease. If someone's a carrier, generally they do not have symptoms. If both parents are carriers, that means that there's a 25% chance that a child will inherit those two copies of that changed gene and develop disease, a 50% chance that the child would be a carrier, and a 25% chance that they would inherit both of the functional copies and then not be affected. Maternal inheritance is generally unique to conditions where the genetic change is essentially within the mitochondrial genome being passed along via the egg and not the sperm. So we'll see traits passed along maternal line. So in the image above, or here, you can see an unbroken line in the condition either in pink or blue. However, anytime that the condition is inherited into an individual blue, male, you can see that the next generation there does not have that condition expressed, which can be important in terms of counseling and recurrence risk to identify the specific type of disease that's occurring as they have different means of being passed along. So to summarize this, here's a case of said maternal inheritance. So the patient who presented to us was a 45-year-old woman who was recently informed by her full brother that he had lost his vision rapidly over the course of approximately 2 months. At the age of 42, first in his left eye, followed 2 months later by his right eye. He had genetic testing in an outside facility that notified him that he was homoplasmic for the classic Leber's hereditary optic neuropathy, or LHON for short, pathogenic variant that is listed here. And upon learning this, the patient sought genetic testing for us to see if she, after having testing, to see if she had that same homoplasmic variant. She did. So to explain, LHON, in short, is a genetic condition that affects the mitochondria, typically presents with painless, often sudden central vision loss, typically starting with one eye and then moving to the other. There can be some extraocular symptoms as well. Typically, it affects young males, but can occur in females or later in life as well. And it's caused by specific variants in the mitochondrial genome. Again, the most common variant I listed here on the screen. Typically, this happens given the eye requires a lot of energy. So when the mitochondria can't produce enough of that energy, these nerve cells don't survive, and that leads to that vision loss. However, this is complicated by what's called incomplete penetrance. So even though one may inherit this specific variant, not all of those individuals will go on to actually express symptoms. Based on empiric evidence, we see that about 50% of men, but only about 10% of women tend to develop symptoms when they carry this variant. They've noted that there are some ways to reduce your risk, including avoiding smoking or heavy alcohol use, and in terms of preventing symptoms and otherwise, or keeping an eye out for things. Obviously, those are required as well. There are some emerging treatments in terms of analog to CoQ10, but that's kind of beyond the scope of this talk here. That said, you can see our family history highlighted here. So the patient that we saw with the arrow there, and it immediately shows that multi-generational history, maternal line of vision loss, but again, not expressed in every individual. Looking at this means all three of her children inherited the variant from her, though we have not done testing on any of them at this point. But that again doesn't mean that they will express vision loss, again, because of that incomplete penetrance. So we highlighted before, historically, we see about half of male carriers and about 10% of female carriers develop this vision loss. However, looking at this family, that doesn't align specifically with those numbers. So that's just generally averages, and environmental impacts can play a role as well. So this is just as a highlight here, this is in contrast to those autosomal dominant conditions where we see that 50% risk, or those autosomal recessive conditions where we see that recurrence risk at 25% in each pregnancy, versus mitochondrial inheritance, which we're seeing here, where there's that 100% transmission from an affected mother, but the sex of the child can impact said expression. So while testing can confirm who carries the familial variant, again, it won't always tell us whether or when that person will develop vision loss in this case. For asymptomatic children, we discuss timing and goals. It depends from condition to condition. Delaying testing until a child can participate in decision-making is one thing we consider. Typically with adult onset conditions, unless there's a clear medical benefit to knowing early, and there's a deep discussion we typically have around that to ensure we're weighing the autonomy of the child as well. So given the homoplastic nature here, we can assume the children would carry this, but all said testing would be available if they wanted to confirm that. But again, the big things here are the modifiable risk factors of avoiding smoking, tobacco, heavy alcohol use, to kind of protect that risk that may be there. For reproductive planning, options typically include donor oocytes or donor eggs, as well as consultation with reproductive specialists for advanced options, but there are some legal regulatory points there, a little bit beyond the scope here. But at present, this patient was really interested for her health, but we did discuss sharing information with her children in a developmentally appropriate manner. But with that, I'll pass it off to my colleague for the next portion.
Thank you, Andy. It's a great case, and it is very hard to understand sometimes when you get a result and you don't really understand why that doesn't translate directly to disease or vice versa. But again, this is something where the discussions matter a lot. So thank you for that case. All right, Rebecca, you're up. Unmute, Rebecca.
All right. I forgot to turn my screen on before I put my slides up. So I'm going to present a case that highlights a little bit of the genetic counselor's role around navigating care, access to genetic testing. So a little bit different than some of the others that we've talked through so far. So this is a patient that presented with cardiomyopathy and heart failure at 5 days of age and ended up having a heart transplant at 6 weeks. So he's this gentleman right here, little guy right here. Genetic testing shortly after the transplant actually ended up identifying a tafazin gene variant, which was consistent with a diagnosis of Barr syndrome. Barr syndrome is a mitochondrial disorder that impacts the mitochondrial membrane, follows X-linked inheritance, and typically presents as cardiomyopathy, muscle weakness, neutropenia, or kind of low white blood cells, growth issues. Shortly after the little guy was diagnosed, we did find that his older maternal half-brother also had Barr syndrome, although had very little from a cardiac kind of symptom presentation, so had not really been appreciated or diagnosed previously. So I first meet this family in 2017 when the initial patient was just 2 years old, and meeting with them kind of gather the full family history. And at that time, it didn't know genetic testing in this family had really gone beyond the nuclear family. So these two boys and their mother, who had been determined to be an obligate carrier because of their diagnosis. So at that time, you can see that there are many other people here who would be at risk given an X-linked inheritance diagnosis, and we recommended carrier testing consideration in sort of the maternal aunts and the grandmother. Fast forward a little bit, a pandemic happened, a new baby kind of was in play. So it was a number of years before this family kind of came back to clinic. And what genetic counselor is part of our role every time we meet with a family is we get updated family history information. So at this time, it became they shared that the grandfather, this gentleman, had actually been in the interim diagnosed with hypertrophic cardiomyopathy, which is a condition that causes an enlarged and weak heart, and that a cousin had been diagnosed with bradycardia, and it is a maternal first cousin. So we ended up talking again about the importance of genetic testing. Hypertrophic cardiomyopathy is not a very typical presentation of Barr syndrome, especially in an adult, but it is reported. And so we talked again about testing. I actually assisted the grandfather with genetic testing and chose to do hypertrophic cardiomyopathy genetic testing that would include the tafazin gene as well. Interestingly and of note, the grandfather's testing came back negative for the tafazin gene change, but we found a pathogenic TTR amyloidosis variant that explained his cardiomyopathy. And the maternal first cousin with the bradycardia, his genetic testing came back negative. Shortly thereafter, I pushed again kind of for the maternal grandmother to get testing because she would be the one to be most informative to all of those other aunts, and she tested positive. So at that point, I put together a family letter to try to help and share this kind of information out to the other family members, especially her sister, and many of these individuals lived outside of the United States. I also went so far at that point in time to find a resource in their country outside the US that would be able to help provide some assistance with genetic testing, and kind of shared all of that information. Fast forward a little bit again, my family comes back about a year later to our clinic and shares the news that they are pregnant, unplanned pregnancy. They had just had a CVS. It was kind of pending, but just the day before had been told that the baby was a boy. Shortly thereafter, a prenatal diagnosis of Barr syndrome was made in this little guy, and our team went into planning kind of mode. So we assisted with recommendations for prenatal care, setting up a delivery plan. We recommended fetal echoes throughout this pregnancy for this little boy, and at 33 weeks, his echo demonstrated very severely depressed heart function and dilated cardiomyopathy. So definitely not it looked kind of bleak, the outcome for this little guy. We initiated discussions and plans for delivery where there would be an acute cardiac care available, a hospital that if he needed to go transplant list, he could go transplant list, and also encouraged a conversation around discussion of compassionate care use for a research medication that I think this community is familiar with and has since been approved for use in adults with with Barr syndrome, or older guys with Barr syndrome. My role through a lot of this was a whole lot of emotional support and check in with this mom as she was going through these stages. I helped reach back out to our Barr syndrome community and find some other moms to kind of be her sort of close little cheerleader pack. So she had somewhere to go kind of with all of this that she was carrying. Baby came not unexpectedly, very difficult neonatal course, but we were, because of the planning, able to start kind of this research medication when he was just 5 days of age. Ultimately, the kind of silver lining of this story is that he did have cardiac improvement and was able to not get transplanted. He has normal heart function, 6 months, and actually going on year and a half, 2 years kind of out at this point. So this is really kind of I think, a success story of awareness and access to care and being prepared when something is around, when you know a diagnosis. I wish that was the end of the story, but this summer, the mother comes back to me about her sister's 18-month-old son who lives outside the United States. That little guy at 18 months old had just been diagnosed with heart failure, and literally one message in my mailbox said, he's in the hospital, he's got heart failure. By the next morning, there was a message in my mailbox that this little guy had passed away. And to add extra emotion to this situation, the mother of this little guy that just passed away, currently 7+ months pregnant with a male baby. At that point, you know, I'm told, I talked to everyone I could find in this country and was told that there was not even an option for amniocentesis in this country at all. That fetal echocardiograms were also not something that is even possible or available. The resource that I had previously given this family for genetic testing options was still there. But at this point, I'm learning that this family has no insurance, extremely limited financial means, and can't afford to do the genetic testing through the resource that had previously been given. So our team put together a letter kind of urging the highest level of delivery care that was possible in this country. And also I dug up some agencies and provided them to the family, telling them maybe it was a long shot, but is there a way to find someone who could help sponsor getting this little boy here to the US? And then I went to work to try to find a way and set up a way to get an answer very quickly for this mother about her own carrier status, even though I was convinced the local team outside of the US was not, which I just couldn't believe. So I was able to work and find a laboratory that could send kits to this other country and actually had very reasonable self-pay rates for targeted testing. I met with this family in one giant Zoom call that included the local mother, the grandmother that I had tested, and then all of the aunts logging in from kind of all over the place. I recommended to TAS carrier testing for all of those who hadn't had it. And I also did not let them forget about the TTR amyloidosis risk that all of those women and aunts and my patient's mother herself were at risk for as well, which has a cardiomyopathy risk for themselves. The mother's pregnant sister, we were able to confirm her carrier testing shortly before delivery. So they were very kind of giving as much care as they could around her delivery. And we, at the time, had sent an extra kit preemptively for the baby so that as soon as he was born, they could do a cheek swab and get it back to the lab. Thankfully, he was negative, right? So the story had a happy ending in the end for the baby that was there. But this could have been very, very different had that baby been affected as well, just given that we couldn't prepare. So with this, I think my take homes are just that genetic counselors are really well positioned to guide genetic risk assessment across families. And we also, access to genetic testing and a diagnosis can have a meaningful and sometimes life-saving impact on medical care for many mitochondrial disorders. I think genetic counselors are also really well informed about the different genetic testing options and resources. In this case, you know, my initial plan wasn't maybe the best plan for this family, and I didn't realize that. And I'm humble enough to admit that I wish I had known that sooner. You know, and so I think my key key take home when they asked us to kind of come up with a key question that you should ask is, if you come up against a wall where it seems like something can't happen, or you can't get testing that you that feels like it's appropriate, just ask again, ask it, ask your team, are there any other options? Are there any other resources? And see what we can come up with, because sometimes there are other ways to figure it out. And that's it. Thank you.
Lovely. Thank you, Rebecca. And thank you to all of our counselors for these incredible cases and teaching points. We maybe if everybody can come off their cameras for just a minute, come on, turn their cameras. We've somehow managed to fill up an hour already, basically, with a really wonderful sort of range of discussion points and topics. We've also, thank you to all the counselors who have been answering questions during the entire session. These are posted in the question and answer section. You can find these answers. I did want to highlight a couple of questions that I thought were important. Just take a couple minutes, and then we're going to wrap up, I think, right after that. So one of the questions that came up a couple different ways was regarding what to do when like how to sort of understand the range of testing options that are out there. So different labs, different kinds of tests, different ways of interpreting those tests. Does there need to be mitochondrial specialization? I don't know if anyone typed and answered any of those questions, but if you did, maybe you could unmute and kind of give a really quick, like 30-second take on the variety of testing options that are out there and whether or not there's a better place to go to for specifically mitochondrial testing. I know somebody answered one of these questions, so just unmute and answer.
I guess I'll take it. With the broader base testing like genome, this is going to solve a lot of these technology problems we're having interchangeably. Cost is an issue, sample type's a problem, how to do it. If you find something and need a specialist, but you can get like your general geneticist or someone who's savvy like Divakar and works with a genetic counselor, it doesn't have to be a mito specialist to help get you the testing that you may need.
And I think, Colin, you brought up sample is a problem. Like there's different tests that are done in different places, which you kind of highlighted. But just to remind people, some places might do a cheek swab, some places might do a blood test. You've heard of muscle biopsies. I'm sure a lot of you guys have heard of those things. So there are different tissues that are tested. But again, a whole genome is going to go a long way to covering a lot of this stuff. And it will also not solve the problem of mitochondrial testing being different, mitochondrial genome being different in different tissues. So both of those things are still going to continue to be challenges. In terms of like the labs that people send things to and the sort of interpretation, there will be some differences in the technology of those different labs. I think they're converging on better technology. So again, a lot of this comes down to reanalysis and sort of paying attention to the field. Another question that I think came up in a couple places was, what do we do if, like, I know we've talked about it here, you guys have all given examples of it, but maybe somebody can just give a quick takeaway on just a really brief take on what do you do when you get to the end of the testing paradigm that has been offered to you and you don't have an answer? What would you do next? And sort of what is your message to people who have maybe reached that point?
I guess I'll take that one. I would say that if you feel comfortable with your team and feel like they have carefully worked through the evaluation with you, I think that, if you feel like you have lingering thoughts that things haven't been addressed or well answered, then by all means seek a second opinion. But if you feel confident in the evaluation that you've had and the team that you've worked with, then sometimes it's just a matter of waiting and letting the technology catch up. I know that is a less than satisfying answer and a very hard thing to ask a family or a patient who's struggling to do. But sometimes, we just have to let the field get smarter and the technology get better. So yeah.
And just to piggyback on that, maybe anyone else could mention very briefly, people have asked about like availability for virtual consultations and things. I know there's a lot of differences in terms of like who can and can't do that. What would you recommend to people who are seeking somebody who's outside of the sphere of their immediate care? So like if they have to travel or if they have to seek out somebody who's at a different place.
I mean, that's a tough one because it is very specific. So some genetic counselors will have licensure that is beyond their states. It's a licensure is done by a state-by-state-ish way for genetic counselors. Some counselors are only licensed in their own states. Some have some licensure outside of their states. Many physicians, though, do not have licensure across state lines. And so it really depends on what type of evaluation you're seeking and you need. Whether a genetic counselor can help you independent of an evaluation with a clinician. I don't know, would anybody else add anything to that? It's a little bit of a tricky question given we don't know how you might be presenting.
Yeah, I think I would just add to that real quickly. Yeah, it depends on, having that in-person physician can be really helpful. There are those telehealth genetic counseling practices that can sometimes help facilitate working with a physician who maybe has a larger state licenses. So, it behooves you to ask and see, which clinic may be able to help or not.
Well, we have come up against the hour. Nicole, I'm going to throw it back to you. I just want to thank all of our panelists. You guys were wonderful. We again appreciate everybody's attendance and the questions that everybody asked. Thanks a lot. We look forward to seeing you at the next Ask a Mito Doc, which Nicole can tell you about.
Yeah, absolutely. Thank you everyone so much for your participation tonight and answering the questions that came through in the Q&A. A lot of great ones tonight. I did want to make sure that you are aware of our upcoming December Ask the Mito Doc, which is going to be wrapping up 2025 with our Mito Docs. And that'll be on Wednesday, December 17th at 7 p.m. Eastern Time. We also have a special webinar coming up as well at the end of this month on November 25th, and that's for the 2K or TK2D Kaijevi talk. So that's also coming up. And there was a lot of people that talked about not having genetic testing done. We are offering our no-cost genetic testing program through the UMDF. So make sure you visit umdf.org/genetic testing so that you can learn the details on that. But everybody, thank you so much and have a great rest of your evening.